afternoon from ACC 2016 in Chicago. We have the honor here to have Dr. Roxana Mehran, a true expert in interventional cardiovascular research and clinical trials. A lot of trials, interventional cardiology, have been presented in such short time, and we would like to ask you a few questions. First of all, what do you think about the results of the Partner 2 in intermediate risk patients?
First of all, thank you for having me here, and it's wonderful to have CVCT here at ACC 2016. Everyone should come to the meeting in December, in early December, CVCT. It's not a meeting to miss, and the coverage of the clinical trials here have been great by you, all of you, and it's wonderful to have you, and thank you for having me. So, Partner 2A, I think a tremendous, probably the most important trial here at ACC, completely changing our vision and continuing to show that perhaps transcatheter aortic valve replacement is going to be really the way to go and the new gold standard. Obviously, non-inferior to surgery, a tremendous trial with over 2,000 patients, TAVR versus surgical replacement in patients who are at intermediate risk. Previously, it was high risk inoperable patients. Now, moving the needle towards more intermediate risk patients with basically exactly the same results. In fact, the transfemoral patients had even a much better result than surgery. Really giving you a very important implications that as we move forward with the next generation of devices that's already available, this was with the XT, so we're already on to the next generation, and the S3 was just presented today, showing a tremendous enhancement in early outcomes. We only saw 1-year outcomes, but still, a very important new change for how we look at TAVR. And I think what this means is we're going to move to the lower risk patient population. But before we get so excited, we still need long-term follow-up. We don't have the long-term follow-up in these devices as yet. I think that some of the studies have embedded the valve mobility and proper pharmacology, and there are some next trials that are going to look at that. So this is all going to be very, very exciting new era. You better get your skills up in TAVR because it's definitely going to take over. So it's a tremendous step forward.
This is definitely very exciting, and most likely this is the real future interventional cardiology. Do you think that in the TAVR space, with the impressive SAPIENS results with the SAPIENS 3, we are ready to move to the low-risk patients, together optimization of pharmacotherapies, intraprocedural, post-procedural?
I think we're ready to go there for a prospective randomized trials. I don't think you can take those trials and say, well, that's going to be the same with the lower risk patients. So I think that we need to do that, and we need to make sure that we do it in a cautious way, the way it is already planned both by Edwards and Medtronic. I think they're going to do a fantastic job making sure that they do the proper clinical trials, well-powered, well-designed, high-quality trial. But I think there's no question that's already the next place to go.
Absolutely. Let's move toward the coronary space. Also, a lot of very interesting trials have been presented. By just to say one, the Dynami program just presented the DIPOST and the DEFER trials, which were part of the same program. The other trial was presented last year, which was the pre-multi trial. What do you think about these new techniques that have been implemented and tested?
First of all, we really need to congratulate the Dynami investigators. They're doing all of the unanswered questions. Last year, they did the pre-multi, looking at how to approach the patient with multivessel disease who presents with a STEMI. This year, they show us the deferring the deferring your, opening the flow, deferring the stenting procedure, bringing the patient back and doing that, versus post-ischemic conditioning, which is blowing up the balloon after you restore flow to deal with the post-infarction ischemic reperfusion injury. And I think, in my mind, I think it's great that they try to ask those questions. A couple of things, they're negative studies, unfortunately, but the biggest thing is that are they really powered to show for those endpoints? There's small numbers of patients. I don't know that we should throw away the pre or post ischemic preconditioning, or post conditioning completely. I mean, I'm more of a school. I'm more of a preconditioning girl than a post conditioning person. But I think overall these are really interesting and important first steps. But unfortunately, the negative trial makes you sort of say, let me make sure that the next trial, if we are going to do it, that we do it in the largest scale, making sure that we can answer it. But again, congratulations to the DNAMI paper.
Absolutely. Interprocedural techniques are always very difficult to investigate in trials, and very often they do not really match what then happens in clinical practice because no patient is the same. So thank you very much, Dr. Mehran. It's been a great pleasure.
Thank you.
We will meet next year at the
Absolutely.
ACC 2017.
But more importantly, at CVCT, make sure you don't forget to come to CVCT 2016 in the first weekend in December in Washington, D.C.
Thank you.
Thank you.